Members, it's the appointed time. We have a quorum. I call the meeting to order. This is the panel on health services. Item 1, information papers issued since the last meeting. The Secretariat has issued 2 papers for members' reference. You'll find the details in the agenda. Item 2, items for discussion at the next meeting. On the 9th of October, which is a Friday, at 10:45, we will conduct our next regular meeting. The first item for discussion is update on eHealth Plus development, and the second one is proposed implementation arrangements for measures to enhance price transparency of private healthcare services. Members, do you agree? If so, let's go into the third item of today. Prepare for influenza season. Please invite the administration to come in to join us. Attending this meeting are Professor Lo Chong Mao, Secretary for Health, Assistant Director for Strategic Purchasing Office Dr. Christina Moore, Principal Assistant Secretary for Health Ms. Trinky Chan, Commissioner for Chinese Medicine Development Dr. Vincent Chung, Head of Community Network Primary Healthcare Commission Ms. Chen Yuk Sim, Head of the Emergency Response and Program Management Branch Dr. Leung Yu Hong, Assistant Director for Health Drugs Mr. Frank Chen. We have also the Director of the Cluster Services Hospital Authority Dr. Wong Yu Chung, and Chief Manager Cluster Performance of the HA Dr. Larry Lee. We'll first hear from the administration. Members, if you'd like to speak, please press the request to speak button. Chairman, members, every year in Hong Kong you'll find 2 influenza seasons, winter and summer. However, this year, in the first quarter, we did not see the winter influenza season. For the first 4 months, the influenza activity remained at a low level. It started to rise in May and exceeded the baseline in later June, which means that we have entered the influenza season. We think that the number of cases will continue to climb. We have put in place a number of measures to prepare for influenza. First, vaccination for seasonal influenza to reduce complications as well as admissions. Let me give you information of our work. With our effort, we have administered over 2 million doses. Compared to the average in previous years, the number of doses administered has increased. However, the number for 25-26 has registered a drop compared to the previous year, because in February 2025, there was a case involving a young celebrity. He passed away because of seasonal influenza. As a result, the base figure for 24-25 spiked. In 25-26, we did not see the winter influenza season typically found in the first quarter of this year. So the incentive for members of the public to receive vaccination is lower. Starting from last year, we have put in place a number of enhanced measures. First, expand the scope of the seasonal influenza programs to subsidize those between the age of 18 and 65 with chronic illnesses. We've also expanded the outreach program for schools. Schools may choose live attenuated influenza vaccine or injectable inactivated influenza vaccines. We've seen an increase of about 80% of schools choosing nasal vaccines. We've also provided recombinant influenza vaccines for those living in residential homes or for the elderly. We've improved the vaccine procurement program for family doctors. We have procured a large number of doses for them. We have launched the electronic consent form through the eHealth mobile app to facilitate the participation in programs. We've also enhanced dissemination of information of participating private doctors in vaccination subsidy schemes. We've also maintained close collaboration with different partners and stakeholders. The online appointment schemes has been extended from 16 maternal and child healthcare centers to all 29 of them. We have also over 110 designated clinics under the DH, as well as 25 district health centers and service points, in addition to the 75 family medicine clinics and 38 public hospitals of the HA. They all provide vaccination services. Over 1,900 doctors participated in the scheme, providing services at more than 3,000 service points. We're making preparations for the vaccination program in 26-27. In addition to making sure that suppliers will meet our stringent requirement, we want to ensure stable supply. We improve our procurement program by introducing different suppliers with different brands and different technical platforms. We want to diversify the risk of supply to ensure the reliability and sustainability of supply. We want to also improve the flexibility to enhance vaccination rates. Riding on the pilot scheme on vaccine procurement for family doctors in the 25-26 year, we will enhance this arrangement in 26-27. Eligible doctors will receive 300,000 doses under the program. Those participating in vaccine programs or at least one of the programs in primary healthcare will receive additional support. We'll also streamline the overall procedure by simplifying the registration process. In relation to registration on e-health, since last year we have greatly simplified the consent form arrangement. There will be further enhancement introduced this year, including additional functions so that members of the public may submit the electronic consent form through the app. And in the school year of 26-27, parents may make use of the e-health app to submit consent form under the school outreach program without having to fill in a physical form. We have also put in place an information platform for students so that doctors and schools can more effectively make arrangements for vaccination arrangements. The HA will also put in place a number of measures, including enhancing monitoring, enhancing manpower, increasing quotas, increasing the number of beds, and improving bed flows. They want to work to meet the demand during peaks. District health centers will also be used to disseminate information. The network will be expanded from over 20 to over 40. Services will be made available during long holidays. Evening services and holiday services information will be consolidated for dissemination so that demand will be diverted from A&E. The Chinese Medicine Unit as well as the DH Chinese Medicine Regulatory Office will keep relevant organizations and stakeholders informed. The CMU Chinese Medicine Unit will encourage Chinese medicine clinics to put in place additional service sessions as well as increasing quotas. The information will be disseminated onto relevant platforms. The Chinese medicine clinics come training and research centers will enhance services. The Hong Kong Chinese Medicine Hospital will increase service capacity. Starting from December this year, there will be around-the-clock admission service to accept suitable influenza cases to relieve pressure in the public hospital. I'd also like to give you some figures. In 25-26, the number of cases of serious complications as well as deaths Without vaccination, the number is 5 times higher than those who have received vaccination. Those living in residential care homes age above 65, those who have not received vaccines and have complications is 4 times higher than those who have received vaccination. This shows that vaccination is very effective in prevention of serious cases. Previously, someone has posted on social media that for the health of their elderly family members, regular vaccination will be arranged for the family members. It is commendable because it will be for the protection of the health of elderly family members. So for your elderly family members and those living in RCHEs, they should receive vaccinations every year to protect their health. I hope to use these stories to remind members of the public to receive vaccination, to increase vaccination rate so that we can reduce the number of death cases and serious cases. We look forward to working with different quarters of society to make the best preparation for the coming influenza season to protect public health. We have received one submission before the meeting, and it has been given to members for reference. So far, 5 members have pressed the request to speak button. They are Mr. Kitson Young, Mr. Professor Chen Wing Kwong, Mr. Duncan Chiu, Mr. Chen Pui Leung, and Ms. Rebecca Chen. 4 minutes question and answers included. Mr. Young. I see that the government has done a lot of work to prepare for the influenza season. I'd like to talk about vaccination in schools. The rate has increased to 99%. Only 18 schools did not participate. I would ask the government to do more with their publicity campaign because vaccination is effective in ensuring the health of the general public, in particular elderly and young people. Vaccination rate for elderly people. Those above the age of 65, including staff at RCHEs, the vaccination rate has dropped. Are there any ways to arrest the drop and boost the vaccination rate? Those between the age of 6 months and 2 years, the vaccination rate is only 27%. It's low compared to other age groups. Are there any ways to boost the rate? Those between 6 months old and 2 years old, they have a weaker immune system. They need more protection. So can you do more, say, at the maternal and child health centers? Can nurses help with giving more information so that parents will arrange for vaccination for their children? Another question is about doses at private clinics. It now stands at 300,000 doses, which is quite good. How do you ensure that private doctors will make good use of these doses for those who are in genuine needs instead of them holding for their own use? We don't want abuse. Secretary, I thank Mr. Kitson Young for his concerns about vaccination among the young and the old. For the elderly, the overall figure is quite good. The rate at RCHEs is higher than the number in the community. For the former, is 79.1%. I am more concerned about carers and staff members in the homes. The rate is only 30%. It is indeed a concern because these carers at residential care homes may bring the virus from the community to residential care homes. I asked them to learn from the story who arrange for vaccination for the 80-year-old family member every year. we also want to enhance the rate for children. You mentioned that the rate is rather low for those between 6 months old and 2 years. The rate has actually increased, but compared to other age groups, this group is lower. I will defer to Mr. Dr. Leung of the Department of Health as to how to boost the vaccination rate.
Maybe I can respond to the elderly group first. So in last year, the rate for vaccination has declined. So we would also like to enhance and increase the rate for them this year. So we would like to start from the community area with care teams involvement. So at the end of August, we would like to give them more information so they can strengthen their district work to outreach to more population and increase the rate for vaccination among this elderly group. We would like to collaborate with other organizations as well, such as the elderly, those who are retired, the retired groups, and with the housing society. We would like to see if we can have some collaboration with the housing society so we can have some outreach within these residential areas, which mainly have elderly residing there. Regarding the staff in the elderly care homes or residential homes, we would like to do what we did in previous years. We would allow vaccination in the centers like previous years. Regarding the children age 6 months to 2 years old, we would like to remind the parents and the family members of them via text to encourage them to take in the vaccination. We have opened all 29 MCHCs for vaccinations. So through the systems, they can also register for it. We will also have SMS to remind the parents. So when they go for these checkups, regular checkups, they will also be reminded that they can also do these vaccinations. And also, the healthcare professionals' advice is very important. So in MCHCs, when they have regular checkups, the staff there will also remind them to have the vaccination for their young children. So just now, as what Professor Low has mentioned, the data he shared is that there is a 5 times more of severe cases and higher mortality rate if they do not take the vaccination. So with these data, I believe the staff can explain to the parents that the benefits of taking vaccination. Next, we have Mr. Chan Wing Kwong. I have 2 questions. So I would like to refer back to paragraph 12 and 13. So for age 6 months to under 2 years old children, there's only 27.1%. But for other group, it's only 24.5%. So I would like to see if you have any measures to enhance these 2 groups' vaccination rate. Also, do you have any regulations and monitoring system for private family clinics to not collect any extra costs for subsidies. If there are any family doctors who has violated these regulations, do you have any regulations to monitor it? Also, for the Chinese medicine centers, we all know that it is very difficult to get a spot because the queue is very long. So my question is, would you increase the service capacity during the influenza season? Would there be a collaboration between the public hospitals and these Chinese medicine hospital? Will there be any subsidies for the public to visit the private Chinese medicine clinics so it can respond to the high demand for Chinese medicine services during the influenza season? Thank you. Thank you. So, Professor Low, please. So the questions that you have raised is similar to the previous members' questions. We highly focus and we are very aware of the young children and the elderly vaccination rate. As mentioned by Dr. Leung just now, in MCHC, we highly emphasize on the vaccination and we have a lot of promotion work done by our staff. In terms of procurement, we have 100,000 vaccination last year. We have offered a good pricing for them and monitoring, and we hope that the public can enjoy this service. This year we are adding it to 300,000 doses. Regarding the Chinese medicine service, we have increased the quota for our Chinese medicine clinics, training and research centers, and also our Chinese medicine hospital. So more members from the public can enjoy the Chinese medicine service. The subsidies has increased as well. The government has subsidized this Chinese medicine service. The remaining part I'll pass to Dr. Vincent Chong, our Commissioner for Chinese Medicine Development, to respond. We have all along been collaborating with the private sectors. We have encouraged them to lengthen the service hours during the influenza peak seasons. In terms of promotion, we also would like to share the information of the extension of service hours in our websites, Health Plus app, and other platforms. But of course, we also monitor our 18 districts, Chinese medicine clinics, training and research centers, and our Chinese medicine hospitals to adjust our supply of service so that we can cater for our public need. Thank you. Chairperson, I have a follow-up question. Because as you mentioned that there are a lot of Chinese medicine clinics, you have said that they have extend their service hours, but you have not mentioned about any subsidies. Would there be any subsidies for these private clinics so that the public can enjoy these service so that they don't have to rely on the government, the government hospitals. Would it be possible to offer a more economical way for or option for the public to enjoy these Chinese medicine service? Thank you. Apart from the medical voucher, we have been increasing the number of quota and capacity. Actually, the private clinics have been supporting. We have more than 320 clinics. I think I can respond to it. There is a total of $800,000 subsidies that the public can use, and we also have subsidies from the voucher for the elderly medical voucher. So we believe that those who are able to afford will be able to pay for their own medical costs, but those who are in financial need will be able to subsidize them. So the resource can be allocated well. Thank you. Next is Mr. Duncan Chiu. Thank you. So I'd like to compliment on our Health Plus app. We have a lot of new functions. So I'd like to ask, how are you going to inform our parents and schools and children or students to use these new functions? Because there are a lot of parents network groups. They have a sharing of information there. Will we get involved in it? Because the usage of HA Go and also the eHealth app, we have these websites. I would also like to address the staff vaccination rate for the residential homes because it has dropped in these years by 30%. Will there be any special measures or incentives for the staff so that they can go for vaccination? Will the nasal vaccines be available to them, because a lot of them are fear of the injection? Thank you for the questions. Responding to the schools outreach program for the consent forms in June and early July, we have done an introduction talks with schools and parents to talk about our new way of collecting the consent form. So we have encouraged the schools to inform the parents as well. We also will prepare some guidelines for parents because this is a new measure that we are collecting the consent forms through our eHealth app. The guidelines will be a step-by-step procedure, so they will be easy to follow and complete the consent forms. We would also inform the parents through our app and also the social media to release information to them. We would also seek for disseminating the information through the parents' groups. Regarding the elderly homes, according to our understanding, it may not be relevant to the nasal vaccines, and we are not offering the nasal vaccines to the staff at this moment. But last year, there's a factor, as mentioned earlier. Usually, the first 8 weeks of the vaccination is very important. Usually, we have 70% of the vaccination injected. in the first 8 weeks. But last year it was quite special because it clashes with the summer influenza season. For elderly, there could be a possibility that during that vaccination period, they are suffering from different medical conditions or physical conditions that are not suitable for vaccinations. But we would also like to encourage different staff for these elderly homes for vaccination. I'd like to also ask a follow-up question for Department of Health. There are a lot of resources being shared in our platform, but I think the promotion can be done better. Thank you.
Next, Mr. Perry Chan. Well, members expressed concerns about the young and the old. Secretary has already answered. I'm not going to repeat what's already said. Vaccination rate 27.1% among those between the age 6 months and 2 years is rather low. A lot of parents think that there will be side effects from vaccination. Perhaps their understanding is not accurate enough, which explains the low rate. In relation to the school outreach program, do you include staff members? Well, do you include nurseries and kindergartens? Because there are pupils. And influenza is passed from people to people, so they are also at risk. Well, the increase of doses from 100,000 to 300,000 doses for family doctors. What factors do you take into consideration? What did you take into account to arrive at the additional doses of 2-folds? The outreach program is also covers kindergarten, but those under the age of 2 belongs to preschool groups. A better platform will be the maternal and child health centers, because newborns will visit maternal and child health centers for health assessments and vaccination of other types. Sometimes parents might hesitate to give their children influenza vaccination after they have received other vaccinations. We have enhanced public education at maternal and child health centers. We want to give them a correct understanding so that they will not be misled by reports and stories in the media and on social media. Sometimes parents only have an inaccurate understanding of the side effects of vaccination. What about the 300,000 doses procured? I will defer to Dr. Moore, Assistant Director of Strategic Purchasing Office. Dr. Moore? Thank you for the question. In 25-26, we have procured 100,000 doses under the pilot schemes to test the water. It was received very well. Within 2 months, the 100,000 doses have been snapped up by private doctors. Given the positive response and the information we have received in practices, as well as the capacity for additional doses procurement, we think that we can increase the number of doses to 300,000 doses to stabilize the supply in the private sector. We've also expanded the scope to doctors participating in healthcare programs, in addition to those who sign up for the chronic illness co-care program. Well, in addition to co-care scheme, we've expanded the scope to doctors participating in, say, colorectal cancer screening program and other screening program. We have increased the number of doses. This will give a better foundation for our next step forward. Are the doses confined to those participating in the vaccination program? We want to subsidize doctors participating in the scheme to use the doses in target groups. So the doses will be used on people in the target groups. Next, Ms. Rebecca Chen. We see an improvement in the vaccination rate year by year. But it's about timing. 99% of schools have signed up the outreach program. That's last year. But if you search for information, the first influenza season was reported on the 12th of September in a government press release. And then on the 23rd of October, there were 4 cases among children. And within less than 2 weeks, there was within 2 weeks after school have started, there were outbreaks. So vaccination given in November or December will give this result. I received information from my daughter's school to receive vaccination at the end of November. I did not want to wait, and I took my daughter to a private clinic because the government program started on the 22nd of September. In August, we start receiving numerous notices from schools. Can you bring forward the start of the outreach program? On the 15th of September, staff members of the hospital authority said that they have received the vaccination. The chief executive and accountable officials have received the doses on the 26th of September. So can you bring the outreach program forward, say to September? Young children, do you have a solution? Do you know the situation mothers are in? The maternal and child health center close at 5 and will not open on Saturdays and Sundays. Will you do more to help parents? If you want more people to take up the vaccine, currently standing at a rate of 20% or so, then you need to do more. In addition to maternal and child health centers, during special times, perhaps you will send special mobile vaccination centers because that's the practice adopted during COVID. I do think that the vaccination rate for those under the age of 2 is too low. For hospital authorities, perhaps vaccination can be arranged in a follow-up. And if a follow-up session is after September, perhaps you can call them back to receive vaccination, say in September, Secretary. We are glad to learn that more schools have participated. Only 19 schools did not participate. There is a participation rate of 99%. It is a record high. We want to bring forward the schedule of vaccination. Basically, it's all done before the end of October. The WHO decides the proposed strains, and then in February or March, and then manufacturers will start to work. We receive vaccines in around September. We want to mainly protect people against the winter influenza season. Last year was different because the summer season started late. It started in around September. The number of serious cases mentioned by Ms. Chen was a continuation of the year before last. Vaccination is mainly for protection against the winter influenza. Last year, if the summer influenza season was longer and extended to the winter season. As a result, vaccination could not as effectively protect the latest season because they were for the season before. We try to start the outreach program as soon as possible, but we're talking about close to 200,000 doses. Of course, ideally, we can administer all on the first day when the vaccines are received. We're talking about a period of the time needed to administer close to 200,000 doses. We thank private doctors for rendering help. You mentioned about secretaries receiving vaccination. We do so as a demonstration. It's not the case that we have taken their places. No, I was using the example to illustrate that vaccinations arrived in September, so vaccination can start in September. It's not the case that I was trying to say that secretaries were taking the places and the available doses from children. We would like to start the outreach program as soon as possible, but we're talking about over 100 and close to 200,000 doses. They cannot be administered in one go. We have asked private doctors to participate in the outreach program. We will try to bring it forward as soon as possible. I'll defer to Dr. Leung in relation to the age group under 2 years. What about the group between 6 months and 2 years? As I mentioned, Maternal and Child Health Center plays an important role. The doses for this age group, including private doctors, the rate is about 46 or 50%. The ratio is about 4 to 6 or 5 to 5 between healthcare centers and private doctors. More of them were administered in private clinics because parents bring their children for consultation and do that as well. We have 1,900 participating doctors, so we have over 3,000 service points. Some clinics may not operate just between 9 and 5:30. So parents don't necessarily have to bring their children to the maternal and child health centers. They can do so at private clinics. Let me give you some information about seasonal influenza. The most effective period of a vaccination is the first 3 months. WHO talked about annual vaccination in preparation for the winter influenza season. In Hong Kong, that season starts at the beginning or middle of January. The Scientific Committee on Vaccine Preventable Diseases of the CHP proposed vaccination in October and November because if you get vaccinated too early, the effectiveness dropped by about 8% per month. We want to complete all vaccination before December because the next season starts in January. And we're talking about close to 2,000 schools. We need to give them time to administer all doses. So we have to consider supply and science. We think that starting the outreach program in the second half of September is the most appropriate time. Of course, that is under the premise of vaccines having arrived. As the Secretary said, we try to do it as early as possible. Next, Mr. Peter Chiu.
Thank you. Regarding the vaccination program, I really support the government to implement this because I really have witnessed that my colleagues who has not taken the vaccination, they really have very severe symptoms. In the past decade, I have always taken the vaccination. We are the role model to receive the injection to support the public to do so. In my own precaution measure, if I have noticed that someone beside me are starting to have some flu symptoms, I immediately take some Chinese medicine, maybe like herbal tea to control. And with the vaccination, I really have not got any serious flu symptoms. So I think the effectiveness is recognizable. In paragraph 8. There are more than 2,000 schools and over 90% have joined the outreach program. May I know, are there any reasons behind the schools who do not join this school outreach program? Another issue is regarding the elderly who visited the public hospitals for regular checkups. Would they be able to take the vaccination there as well? And number 3 is, Professor Low, your influence is very huge. So when you mentioned about the weight earlier, a lot of the members from the public really get a scale back home to weigh themselves. So for schools, I think the outreach program, we really are grateful for the schools who support, because the parents it's actually provide convenience to the parents, but of course they have the option of not joining the outreach program but bringing their kids to their private clinics for vaccination. For those who did not join this outreach program, their reply to us is that they will arrange their own vaccination, and most of their parents from these schools will have their own arrangement. This is the general response from them. But 18 schools is really, really a small number, because over 2,000 schools have joined our program. And for schools who join this program, although not all the parents are agreeing their children to take the vaccinations, but it's already a good indicator. As you mentioned just now, we thank you for your compliment. We mentioned about the weight control. May I know, for chronic disease and elderly, when they go to the specialist clinics, will they be able to join or receive the vaccination when they are doing these checkups? Yes, they can do so there. Thank you, Chairperson. Next is Ms. Grace Chan. I remember that Professor Low has mentioned that you really pay attention to the residential care homes. So I communicated with these care homes. We have already discussed the timeline and other factors. Some other incentives would be like paid leave for them to have vaccination. Mr. Shiu mentioned just now, will there be any sharing of information or data on how many people or staff, the percentage of being vaccinated? We are not trying to make a rank or something, but with this data, it allows the family members and carers of the residents feel more secured to have their family member to stay in this residential home. Thank you. So regarding the staff vaccination rate in our outreach program, apart from the residents in these care homes, we also offer the service to the staff. So the staff do not have to go for vaccination during their leaves. They can do so during their work hours. Regarding the other incentive on showing a label or a sign or sharing the data of how many people have been vaccinated. We have not do it in residential home, but we have done it in schools. So the main audience or our targeted audience would be parents, because this is to let the parents know that, oh, our school has not joined this outreach program, so I need to bring my children by myself for vaccination. So for residential homes, I think it's about residents who has being vaccinated or not. But we are not going to share the staff list and to let other people know that, oh, which staff has not take the vaccinations. Because of course we encourage them because they are also the medium of getting infected. Next is Ms. Christine Fong. Thank you, Chairperson. In early June, no matter it's influenza A or H3, it's influenza peak season. We have seen that there's a high rate of during this peak season. So my question is, since September 25th, you'll have the vaccination for everyone available. Now we know that each member of the public can have one chance of taking the vaccine. So will there be an add-on or top-up? From what you mentioned, the effectiveness is 6 months. Will it be possible? Will it be possible that the cycle is 3 months rather than 6 months? Because the effective period is relatively short. And you can see that the infected rate for children is pretty high. So will there be a possibility of shorten the waiting time for the vaccination? Also, will it be possible to have a higher rate or portion of having nasal vaccines to schools? Thank you. For each infectious disease, there's a different vaccination measure. So for the pneumococcal vaccination has its own features. In the northern hemisphere, in each year, the virus will change every year. So we need to pay attention to how it changes in order to produce the appropriate vaccination to target as the virus. Although the effective period is 6 months, but I wouldn't say that after that it's completely useless. Of course, the best protection period is after vaccination, 3 to 6 months. But again, as I mentioned earlier, our main target is to protect them from the winter influenza season. So for summer influenza season, because of the climate change, the peak season of influenza has changed. And you can see that it started a little bit early. It started in June for the summer influenza season now. So we may need to adjust. Just now we mentioned about the pneumococcal virus for vaccination. We have Dr. Leung to respond. So as mentioned, for age 65 or above, if they are healthy, they only need 1 injection. It will be sufficient. But for the high-risk groups, it's like long-term chronic disease patients, after their first injection, a year later, they may need to have another injection. So we also follow the guidelines from the science committee. If they are of chronic disease, so they would be able to get a free injection the year after. They can go to our public hospitals or clinics for the vaccination. They can also go to private clinics under our vaccination subsidy scheme. Regarding the nasal vaccines, in our paragraph 8.2, our live attenuated influenza vaccines, we have 48,000 doses. So we have increased 80% compared to previous years. For schools, because this is our first year to have all kindergarten, primary school, and secondary school to have the injections, we can see that for kindergartens, there are 390 schools to use this nasal vaccines. Thank you. Chairperson, is it possible, if it's possible, to add this option to our promotion leaflets, because members from the public may not know that there's such options. In fact, all schools have the option of getting these nasal vaccines, and the school can offer both to their parents according to their preference. Next, it's my question. May I know, the timeline for this year's vaccination is still yet to be confirmed, and also for our digital e-platform, I know there's an enhancement in our platforms. Can you share with us what are the enhanced features? Number 3, we have all along been asking the patient for their written consent forms. We have been using the written form. At this period, we are changing it to the digital consent form. Will you come for monitoring, or you will check it by your internal system? Will it be more environmental friendly? Now I also am aware that there will be outreach to schools, residential cares. Will there be outreach program to community living rooms or elderly homes, etc.? For our eHealth and HA Go app, will there be information disseminated for vaccination? Thank you.
Secretary, we've started procurement for vaccines for this year. As I said in my opening remark, to ensure supply, we have enhanced the procurement process. We want to ensure that the supply will not be interrupted because of problems of a supplier. The question was about the exact launch time. I think we have to wait till closer to the time, say September, until suppliers have given confirmations about when the vaccines have arrived before we can start. In relation to consent forms under specific subsidy programs, I would defer to the Assistant Director of Strategic Purchasing Office, Dr. Christina Moore, about giving electronic consent. Dr. Moore. Last year was the first year when we incorporated into the eHealth platform. We've been improving the system. We'll continue to do so in 26-27. In relation to the flow of consent to vaccination program in 26-27, we have put in an additional function so that electronic consent form can be used. So doctors don't have to spend a lot of time putting in data because the consent form has already been given. For parents who have signed up to use eHealth, they can make use of the app to give consent for vaccination for their children. So if the domestic helper or the grandparents bring their children to receive vaccination, there is no need to put any data in additionally. Even for the paper consent form, it's been streamlined as well. Last year was the first time when eHealth was used. Some doctors have yet to get familiar with it. We have enhanced publicity. We organize briefing sessions to give demonstrations using video clips. We have also enhanced our guidelines. We've improved support to our helpline as well as a support section. So if an electronic consent is given on the platform, there is no need to print it out, right? Question was there were also questions about service points under the outreach program. And other end, notification push. I'll defer to Dr. Leung. We will consider whether the program can be available at these service points. Well, I thank the member for suggesting the program to cover elderly housing. We'll consider that. And last person to ask question, Mr. Kisan Yang, second round. I would like to ask about the expansion of the procurement of vaccines for family doctors. It says in the paper that participating doctors will not charge additional fees. Can they charge service fees or assessment fees, or is it the case that the patients don't have to pay a cent? Are there any measures to prevent abuse? The doses under the subsidy scheme, under the procurement program, is for a specific group. Can they charge someone outside that group to receive the doses they have received? Will you talk about papers being, records being printed out for filing in case you will check it? But if there is no mechanism for checking, then it may give rise to abuse. I'll defer to Dr. Moore. Participating doctors cannot charge extra. The information is available in the website. So patients know that there is no co-payment. We have made it very clear in briefing sessions as well. From time to time, we receive inquiries from patients and doctors whether there will be additional charge. We have made it very clear that there should be none. When we have received views, not necessarily complaints, we will carefully follow up with doctors. We've received some questions initially, but we haven't anymore. About prevention of abuse. Target groups receiving doses, the number has exceeded the number of procured. So we have administered more than 800,000 doses for the target groups. Majority of participating doctors have administered more doses to the target group than the number they have ordered. So there is reason for us to believe that it is quite impossible for them to use the doses procured on people outside the target group. If there are any problems, we will carry out thorough investigation. That's the end of this item. Thank you very much. Next item, item 4, cross-boundary healthcare collaboration initiatives. Please invite the administration to come in to join us. Members, if you would like to ask questions, please press the request to speak button. We have with us Professor Lo Chung Mao, Secretary for Health, Mr. Raymond Wu, Deputy Secretary for Health, Dr. Zhou Fan, Senior Advisor, Secretary for Health's Office, Dr. Carol Yao, Principal Medical and Health Officer, Primary Care. We've also invited from the Hospital Authority, Dr. Wong Yu Chung, Director, Cluster Services, and Dr. Michael Wong, Director of Quality and Safety. Thank you. Please take us through the paper. Chairman, members, in the past few years, the SAR government, under the principle of supporting continuous development, we have been actively dovetailing into national development. With the cooperation of different municipal government, we make use of the Hong Kong U Shenzhen Hospital as landmark pilot platform to implement a number of important measures. In 2024, we launched the pilot scheme of elderly healthcare voucher scheme in GBA. We have expanded the scope from Hong Kong U Shenzhen Hospital to 17 medical and dental institutions. In 2025, we further expanded the pilot scheme to add 15 institutions to 9 mainland cities in the GBA. eligible elderly users can choose 21 service points in mainland cities of the GBA to use the voucher. It gives them more flexibility and choices. In addition to the Hong Kong U Shenzhen Hospital, we have more than 40,000 elderly people using vouchers to pay for the outpatient fees. We're talking about 101,000 voucher transactions involving an amount claim of $103 million. We have also implemented a pilot scheme for supporting patients of hospital authority in the GBA. The purpose is to support patients of HA to receive services in GBA institutions. We are talking about 6,100 patients that have received the service with over 27,000 cumulated attendances. In November 2025, we have fully launched the direct cross-boundary ambulance transfer in the GBA, covering Shenzhen, Macau, Zhuhai, and Nansha. In March this year, we have put in place two-way transfer with Shenzhen, Macau, and Zhuhai. So far, 29 patients have benefited from the service. Since 2024, in the 20 institutions, we have launched cross-boundary health record sharing. We have added the functions of cross-boundary health record and personal folder. In December, for health record sharing, the number of eligible persons have increased to over 700 million Hong Kong people. We've also upgraded the function of personal folder to allow high-resolution radio reports and images to be uploaded directly by the hospitals to eHealth, to EHR. In relation to talent exchange, starting from the fourth quarter of 2022, the HA has launched the GBA Health Talents Visiting Programs covering different disciplines such as doctors, nurses, allied health professionals, and Chinese medicine practitioners. Well, this is used to help enhance the quality through mutual exchange and learning. We've also want to make use of advanced drugs and devices for use on the mainland. Well, as at the 30th of April this year, 71 drugs and 91 devices have been allowed to be used in 71 designated healthcare institutions through the measure. We will set up the Hong Kong Centre for Medical Product Registration. We'll be more proactive to introduce innovative drugs and devices for the use in GBA cities. We have a great GBA International Clinical Trial Institute. Together with the Clinical Trial Club, together with the International Clinical Trial Center, they were commissioned in 2024. In December last year, we have established the GBA Clinical Trial Collaboration Platform to provide a one-stop service to R&D centers in Hong Kong and mainland as well as other places. We have used the basis of grade 3 hospitals to formulate a China's International Hospital Accreditation Standards 2021 edition. This is the first hospital accreditation system. Starting from 2023, the HA has restarted the hospital accreditation program based on this standard. With the active support of the government, so far 5 public hospitals under the HA has been accredited. In 26 and 27, the accreditation program will be extended to 2 major acute hospitals to cover all clusters in Hong Kong. In the improvement of acute stroke centers, the Tuen Mun Hospital, Queen Mary Hospital, and Prince of Wales Hospitals have set up green channel as well as stroke centers. The Tuen Mun Hospital and Queen Mary Hospital have also been accredited as level 3 national stroke centers. The work to develop integrated cardiovascular diseases centers will continue to provide one-stop treatment and support. Queen Mary Hospital has received the accreditation. Prince of Hospitals has started the accreditation process with the aim to get the accreditation in the 4th quarter of this year. We will fully dovetail into national development under the 5-year plan. We will accelerate the building of a healthy China and to put in place strategic development. We will promote cross-boundary healthcare innovation to fully leverage our distinctive advantages and to showcase our unique value and advantages to the world. Me and my team look forward to hearing views and receiving questions from members. Thank you. Let me read out the names of members.
Thank you, Mr. Chong Ho Fong, Yang Wing Kit, Chan Hoi Yan, Chan Pui Leung, Grace Chan, Kingsley Wong, Christine Fong, and Jofi Chan. So each person will have 4 minutes, including question and answer. Thank you. Please, Mr. Chong Ho Fong. Thank you, Chairperson. My question is regarding the elderly healthcare voucher scheme for in GBA area. Over 90%, they think that the registration procedure is convenient and are satisfied. And over 80% of elderly person are satisfied with the payment process. May I know what are the 10 and 20% of the dissatisfaction group? What are their reasons? The second question is regarding the 7 complaints that you have received. What are the nature of the complaints? Apart from the regular monitoring and surveillance, would there be other measures for you to monitor so that this voucher system will not be abused and taken advantage of? So another question is, how can you ensure that these pilot schemes venues, they are saying that they are going to ensure their quality of service, but how are you going to ensure them? Thank you. Thank you. Professor Low, please. If the medical service is offered in mainland, it is under the mainland's authority for monitoring, and they have a very strict guidelines for it. So our role, we are the payer for the service, and will ensure that the service is aligned with our health mechanism. I would like to invite Dr. Carol Yao to mention to talk about our monitoring and surveillance, and we would like to invite Dr. Zhou Fan to talk about the complaints and dissatisfaction reasons. Thank you. Regarding the elderly healthcare voucher scheme, we have very strict measures to monitor the institutions to make sure that they go under our regulations. Our measures include regular visits and what they submit to us. Regarding their complaints and media reports, we will follow up on these. Regarding the mainland institutions, we'll go for site investigations. We will study whether, according to our guidelines, there are any violations of our regulations. Regarding our complaints, there are 2 that are still under investigation. From what we have known at this point, it's more about the unclear of the procedures and the operation rundown. So we will follow up with better communication. Dr. Jo Fan, please. In March to April this year, we have a survey done with our pilot medical institutions. We have 1,100 interviewees and 910 interviewees has a satisfaction score of 9.15 out of 10. For those who are not satisfied, they are not happy with the communication and they think that we can enhance on the communication on the procedures and operations. In terms of payment, we can use the digital e-payment platforms, but we require the patient to go to the counter with their identification card for payment. So we'll continue to study and see if we can enhance this payment process. Thank you. Next is Mr. Yang Wing-kit. Thank you, Chairperson. I would like to address the direct cross-border ambulance transfer in GBA. There are 29 patients benefited from the pilot scheme, including 28 patients transferred to designated public hospitals in Hong Kong from Shenzhen, Macau, Zhuhai, or Nansha, and only 1 mainland resident transferred point-to-point back to Zhuhai. As we have frequent transfer between these areas, will it be an expansion to other destinations? Say, for instance, Dongguan, Zhongshan, or Foshan. These are also popular areas for Hong Kong residents. My other question is the cost for the ambulance service. What is the average payment and cost for each transfer at the moment? Will there be a subsidy for our public? How much are they paying at the moment? This is what I care about. The third question is, for our northbound transit, we see that there's only 1 mainland resident at this point. But if there are Hong Kong residents finding that, the service in the mainland hospitals are better, will there be a possibility or option for them to go back to the mainland for medical service? Thank you. Regarding this cross-boundary ambulance transfer, we focus on it's actually made for patients with clinical needs and it's non-urgent cases. If there is any urgent cases, it should be deploying the local ambulance service. So this service is for the inpatient inpatients who has been staying in the hospital for a period of time and they are stable in their condition. So we offer the option of bringing them back to Hong Kong. So we need to pay attention that we are not focusing on the urgent cases, but they are having a stable condition, suitable clinical condition to be transferred. For the payment at the moment, the price is actually set by the mainland hospitals and medical institutions. The mainland ambulance has their own pricing scheme. The ambulance service has set a price for the transfer because it's their ambulance and the length and distance of coming from mainland to China to Hong Kong is quite long, and we have no power, no authority to interfere on how they arrange the pricing. Regarding the local the patients in Hong Kong who want to go back to mainland, for mainlanders, they need to pay if they are staying in Hong Kong hospitals. But in mainland, they are protected by their own insurance plan, so they don't have to pay. For Hong Kong residents, I believe our medical service is already very comprehensive, that we would be able to cater their needs. So we don't encourage our patients to transfer to other destinations because we believe that our medical system has sufficient resources for their treatments. For our cross-boundary ambulance transfer with the four destinations, Shenzhen, Macau, Zhuhai, and Nansha, we have started in November last year. We have a lot of administrative work. And it incurs a very high cost. So we would like to have more study before we see if we want to expand to other destinations. Thank you. Chan Ho-Yan, please. We are very happy to see that we have a lot of measures encouraging the cross-boundary healthcare collaboration. I want to ask in future, in terms of policies between the two mainland and Hong Kong, in terms of our cost bared by our healthcare sector is actually very high. We have 150 subsidy and 200 in our specialist clinics. In terms of our pilot scheme, now the payment is 100 renminbi, and it has remained the same. So if our residents is finding the cost in Hong Kong is high, will there be an option for them to go back to the mainland to seek for medical consultation? Because $100 is very affordable. Now we only have the Hong Kong U Shenzhen Hospital. Will there be other hospitals involved as well? In 2023 policy address, in terms of the procurement, we have mentioned about the procuring the radiology service. Is there a latest timeline for it? My next question is, we are not transferring our responsibility in offering medical service to other cities in mainland. But in our international medical service, we have the international clinical service. So I'd like to ask, what are we going to support in terms of innovation and technologies? How are we going to support to make sure that it's benefiting Hong Kong residents? Thank you.
我哋
Secretary, in relation to our healthcare policy, especially that involving cross-boundary services, as Ms. Chen said in her third point, the SAR government does not aim to shift our healthcare obligation to other mainland cities because it is the responsibility of the Hong Kong SAR. We will take on that responsibility. We have a high-quality healthcare system with high efficiency. As the Chief Executive said, we are going to build Hong Kong into a healthcare innovative hub. So we are not going to shifting our responsibility to other places. We want to introduce complementarity when it comes to cross-boundary collaboration on areas such as talent and the introduction of mainland standards for stroke centers, chest pain centers. All these aim to improve service quality and more services for the general public. Well, for mild cases of people living on the mainland, they may use healthcare services on the mainland. We do not encourage them to do so. You talk about a Hong Kong U Shenzhen University program. There is actually a cost. Well, starting from 2023, so far, 6,000 people have used it. That includes a period when people were stranded on the mainland during COVID. Majority of participants who stay in the scheme are those living on the mainland. It's easier for them to use services over there instead of coming back to Hong Kong. It's quite rare that those living in Hong Kong wants to go back to the mainland to use their services. 25 institutions. That's the national policy. In the Hong Kong U Shenzhen Hospital, we have an international medical center. International insurance companies can make payment. In this area, the international accreditation is important because a lot of international insurance organizations require hospitals to be accredited before they can make payment. So launching accreditation using a national standard will help hospitals to receive payment from international healthcare insurers, especially in terms of direct payment. You talk about procurement of services cross-boundary, especially that of radiological services. We've been following this field. This involved the qualification of professionals signing the radiological reports. There are different recognition systems of the two sides. We need to ensure that the procurement fulfills our requirements. Thank you. Next, Mr. Perry Chen. I want to follow up on the pilot scheme for direct cross-boundary ambulance transfer. It's been very well received since it was launched. More and more people retire in the GBA. The number has been increasing. Currently, The scheme covers non-emergency and non-critically ill patients who meet specific clinical conditions. But with more people retiring in the GBA, the demand for cross-boundary ambulance service will increase. In addition to ambulance in the public sector, would you consider expanding the scope to private ambulance service meeting certain criteria? Those who can afford to pay more can use the private service. This will give flexibility and more options for those living and retiring in the GBA. Secretary, I want to emphasize that cross-boundary ambulance service is for transfer of patients between hospitals. Mainly, the services are provided by designated sending hospitals at a charge. You talk about ambulance service in the private sector. We may consider to include that. But we need to consider the ambulance, the staff on board, the equipment and facilities on board, whether they all meet the requirements, statutory requirements. Say, for example, the staff on board, according to mainland standards, a doctor will have to be present on board the ambulance. That is different from the requirements in Hong Kong. And the doctor on board should be one that is registered and meet relevant qualifications. That's why we first consider ambulance service from the mainland at this stage. We need to consider the overutilization before we map the way forward. Thank you. Next, Ms. Grace Chan. A number of people suffering from serious illnesses and rare diseases told us that because of the high cost of drugs in Hong Kong, they choose to procure drugs on the mainland. So, in relation to this, what is the stance of the government? Have you considered any ways to help them? There are different registration systems for drugs between Hong Kong and the mainland. Payment system is also different. We are aware of the price differentials of drugs between Hong Kong and Chinese mainland. At this point in time, we don't have any plans to make any changes in relation to procurement systems and registration systems. It is a personal choice when it comes to choosing where to procure drugs on the parts of patients. Doctors, Hong Kong doctors will not issue a prescription for patients to procure the drugs on the mainland because it's not in line with rules and regulations. Mainland doctors will not accept Hong Kong prescriptions. Doctors have the duty to provide information to patients so that they are aware that they can make the decision. They can receive the services in Hong Kong or outside Hong Kong. And if the services received on the mainland is for mainland doctors to make the decision. But whatever they do, they have to meet rules and regulations of their respective registration places. Mr. Kingsley Wong, I'm very glad to hear about the cross-boundary healthcare policy. All the government needs to do is to relax the requirements without attracting a higher cost to benefit the general public, and they've done it. I want to ask whether there can be an expansion of the pilot scheme for supporting patients of HA in the GBA. Well, there may be remote places, say Zhaoqing. Even for patients in Guangzhou, Zhongshan, they have to wait for services at the special outpatient clinic. So they have to go there early in the morning, and they will have to spend a whole day before they can come back in the evening. Will you agree to relaxing the criteria so that more patients can benefit from it? And the elderly healthcare voucher scheme in Hong Kong U Shenzhen Hospital, can the scope be expanded? The satisfaction rate is quite high, it's 9.15. Can it be expanded to say the entire Guangdong province, say in Chaozhou, where a lot of Hong Kong people are living? In relation to the China's international hospital accreditation standards, I think it plays into our strength. I understand that our country would like to promote healthcare tourism. This helps a lot. Have you launched any publicities and more promotional efforts to encourage more mainland hospitals to participate in the scheme? Because this will be conducive to the development of healthcare tourism on the mainland. In relation to the pilot scheme for supporting HA patients in the GBA, currently only the Hong Kong U Shenzhen Hospital is included. That's a continuation of a support scheme during COVID because patients at that time were stranded. The target group is patients living on the mainland. At the same time, we have a voucher scheme for those above the age of 65. The scope of service was extended to 9 mainland cities. Currently, we don't think the utilization requires any expansion. Even for the Hong Kong U Shenzhen Hospital, the utilization rate is not that high. We don't see any need to expand it because the healthcare voucher scheme already covers 9 mainland cities. And as to whether the voucher scheme can be extended to other places, we'll look into it. For the GBA pilot scheme, some institutions are quite new. The utilization rate for certain institutions is rather low. Don't forget that it attracts administrative cost. We have to consider whether it's worth the while to expand it to other places in Guangdong province or even to other provinces. Hospital accreditation. It is indeed a very important part of our work. The accreditation body is mainly in Shenzhen, but they have opened a branch in Hong Kong. Part of their work is to help promote China standard to the international arena. In the past, we've always used European countries or America to see when we talk about whether a hospital is up to standard. We want to do more in relation to the promotion of national standards. There is active participation in hospitals in mainland cities, say for example in Hainan. They want to have the first accreditation using China standard in Hainan. Xinjiang is also a location that will help to promote China standards. Well, do you have a number of participating hospitals? According to the latest information, 13 hospitals have gone through the accreditation process. There are two parts of the work. The accreditation process on the mainland. We have to ensure quality. We need to train more accreditators. Hainan is also working on this. In order to launch China standards to the global arena, we need international accreditators. A lot of Hong Kong experts in the area of hospital accreditation are involved.
Next, we have Christine Fong. Thank you. I'd like to continue on the international hospital accreditation standards. Of course, I really support that if we can accelerate the China's international hospital accreditation standards and we can accredit more Chinese hospitals and also our 5 Hong Kong public hospitals to gain the accreditation, including Pamela Yoda Eastern Hospital, Prince of Wales Hospital, United Christian Hospital, Tuen Mun Hospital, Queen Mary Hospital, and we are extending to Princess Margaret Hospital and Kwong Wai Hospital. Will it be extended to other hospitals like Trang Kwan O Hospital, etc.? If the hospital is being accredited, as what Professor Low mentioned, in paragraph 22, under our new drug registration mechanism, we'll have a new registration system. But if, say, for instance, if the drug is being approved in a hospital in Beijing, would it be possible to use it in Hong Kong as well because it's already approved in the hospital in Beijing? Regarding the radiographic reports, we can already upload the reports in our personal folder in our health record. So, may I know, is it staying here in our Hong Kong side, or the storage is also shared in the mainland side? There are 7 complaints in 2026. There are 2 cases that are still under investigation. Since our medical institutions or service points, it has operated only within a year, may I know, will there be a mediation platform to handle these complaints to ensure our quality of service? Thank you. So, Ms. Fong has 4 questions regarding the accreditation. This accreditation is actually very important to medical institutes because it ensures the quality of the medical service, and it will definitely help the hospitals. So we, in 2026 to 27, we are going to expand to our 6 networks hospitals to get this accreditation. But will we extend to others? It will be in our next step. For what in in what you concern most, the Changquano Hospital will definitely be in consideration of this. Regarding the drugs usage, this is about the hospital monitoring and accreditation, but it's not under the drug registration standards. So it's different. If we are using the same accreditation standards, it could lead to some issues. Regarding the e-health platform, we are using a point-to-point method. We upload it from the medical institution and received by the institution in Hong Kong. So this is what we did in to ensure the security of the information. So it's under the same level of protection. Regarding the complaints, now we have over 40,000 cases of the usage of the elderly healthcare voucher. Only 7 complaints. It's a relatively low number, and most of the complaints is not about our medical service quality. It's more on how to join or complete or claim these service. So it's about communication matters. There are some patients who have asked me, oh, why in Hong Kong we can do the surgery but not in China. So they have mistaken the usage of the medical voucher versus the healthcare voucher scheme in GBA. In fact, in Hong Kong, we have a standard, and if they use the e-health platform, they will be able to get access to this information. But at this point, it is not a platform that has both information aligned. So next, I would like to mention about the medical voucher. In early this year, I went to Hainan for a site visit. We know that Hainan is actually a testing point, a pilot destination to use the international medical devices. So I'd like to see if we can expand our usage on the voucher so we can also enjoy these international medical devices. I'd also like to see for the drugs and other medical service, will it be able to cover cancer or other rare disease? According to what I've heard from the experts, they are more familiar with the American or the European standards, but not so familiar with the accreditation standards of China. So will there be more information sharing from the authorities so that the Hong Kong medical industry will have more access and more knowledge on this? Will there be an acceleration on the application for these vouchers, because will there be more manpower in handling this? Thank you. Regarding the second question regarding the medical device, regarding Hainan, Hainan is a very special destination in our national strategy plan. They have a special tax schemes as well. in terms of medical device and healthcare service, it's a special administrative region. They can use the international recognized medical device directly in Hainan. It is similar to our accreditation standards, but it's not exactly the same. So you may have to understand the difference between Hainan and Hong Kong and GBA. In terms of our voucher, the healthcare voucher, we would like to take care of our Hong Kong elderly who are residing more in some of the cities in mainland for their retirement life. So these destinations are what we have chosen, say for instance Shenzhen, Zhuhai, Zhongshan, etc. If we talk about Hainan, we are not so sure how many Hong Kong residents are actually living there. So we are not sure the effectiveness of spreading the healthcare voucher over there. So we don't have a direct correlation to the national strategy on using Hainan as a pilot destination to use the international medical devices. So what I'd like to mention is what we are emphasizing on is we are taking consideration of the population of Hong Kong residents in those cities in order for us to launch different medical related services for them. So as mentioned, we are going to accelerate the drugs registration, medical device registration, as Hong Kong is going to be the international health and medical innovation hub. We are going to accelerate the approval for drugs and also medical devices. We are going to increase our manpower continuously, but I'd like to mention it is not easy to recruit these talents and experts. The whole world is actually facing this issue. They're competing for talents. But we have been trying our best to recruit these talents to enhance our manpower. Thank you. Thank you, Chair. Thank you, Secretary. And thank you all our members. Let's move on to our any other business. We don't have any other business. I announce that the meeting adjourned. Thank you very much.